Good afternoon. Today I'm going to speak to you about therapeutic drug monitoring in cancer chemotherapy and its potential utility in managing chemotherapeutic drugs for cancer patients. So when we think about therapeutic drug monitoring or drug management in general, one of the things I wanted to bring up is that many drugs are dosed in somewhat the same way, in that these are drugs that are the disease or pathologic condition is identified. The drugs are dosed primarily on a milligram per kilogram basis, and then the patient is monitored for a clinical effect or clinical response. And they would follow this paradigm called titrate to clinical effect. So you follow the patient, and then you modify the dose or change the drug to based on the clinical response, and then you repeat this pattern over and over until you have either found the right drug or the right dose or both. But the question we then ask is, with the tools we have available, is this really always the best way to do things? So in thinking about therapeutic monitoring broadly, so we want to start broadly with therapeutic monitoring in general, and then we'll focus it in on cancer chemotherapy. And we want to think about, why do we do therapeutic drug monitoring in the first place? Because we really only monitor a handful of these drugs. Most of the drugs have a strong correlation between the dose and blood levels, so it's predictive. If you know that if you give a certain amount of the drug, then you will get a certain blood level concentration. But in some cases, the blood level can't be predicted from the dose, and there's a lot of variability. We'll talk about some of those reasons for that. And but because that relationship isn't predictable, then measurement of the drug concentration in the blood is utilized, and it's done for a number of drugs. So in order for TDM to be useful, you don't have, as we mentioned, the good, robust relationship between the dose of the drug and the blood level, but you do need a direct correlation between the blood level and the pharmacodynamic effect, whether that's a toxic effect or whether it's the clinical response that you want. So if that relationship is there, and it seems like that's pretty much common sense, right? Because if you cannot correlate the blood concentration with a clinical effect, then why do TDM, which is measuring the amount of drug in the blood in the first place? So, but outside of that relationship, then you also need to have a narrow, well-defined therapeutic interval. So there should be this interval, and narrow is relative to the biologic variability and how much the variability in response is there. But this narrow, well-defined therapeutic interval, there should be, the therapeutic interval is the concentration difference between the minimum effective concentration and the maximum or the toxic concentration. And if there is a narrow therapeutic interval or a well-defined therapeutic interval, then that gives you your therapeutic target range and is useful in therapeutic drug monitoring. Now, there are some exceptions to this, like compliance monitoring. There are some things like antidepressant drugs or antiretrovirals for HIV therapy, where perhaps there's not that well-defined relationship between concentration and clinical effect, but it is known that if you're non-adherent, that's poor therapy. And so maybe you don't have that range, but you have a compliance threshold. And then it's used as an investigative tool. So if you don't see the therapeutic effect or you see unexpected toxicity, then having a blood concentration may help you get to the bottom of this. Or if you see changes in drug effects, that could be due to drug-drug interactions, or perhaps if somebody's taking a nutraceutical or some sort of supplement that may impact that, or you can have physiologic or pathologic changes. And also, as we mentioned, non-compliance. So in all of these cases, drug levels may help you manage the patient, and that would apply to cancer chemotherapy, as sometimes maybe you're wondering, if you've selected the drug, why you may not be seeing a response to that drug in the tumor. Another thing to remember about therapeutic drug monitoring is that the reference intervals are established based on clinical studies, but not necessarily randomized controlled trials. So in this case, when we're thinking about how we set up these therapeutic intervals, it's typically based on a single site population where they've looked at the response rates within that population, and they define a maximum threshold above which you start to see an increased prevalence of adverse events, and you would establish a minimum threshold below which the majority of patients don't seem to respond, and then the amount in between. And that and it's not based on necessarily a percentage, but it's dependent on the investigator at the particular site when they're looking at that, and they just define this threshold. And then other clinical sites either begin to adopt these, or they may perform their own studies based on the result to see how people respond. But realistically, they take these small populations, they get that therapeutic interval information, and it's widely adopted based on the single site study. But it's important to remember that these reference intervals don't apply to each individual or clinical situation. So while it's a population-based therapeutic interval, that may not necessarily apply to a particular individual. Okay, so what I've shown here is a list of drugs that we typically monitor, and you'll notice that chemotherapy drugs are not necessarily included in there. The classic example of where therapeutic drug monitoring began was in the anti-epileptic drugs. And then much of the work today has been done in, and over the last 20 years is in immunosuppressive drug monitoring for transplantation. But you'll see some of the other things, cardioactive drugs, in the anti-infective drug area. The aminoglycosides and vancomycin are primarily the drugs that are monitored, although there is increasing evidence around the utility of antifungal monitoring for voriconazole and posaconazole. Tricyclic antidepressants are monitored primarily to avoid the toxic effects. And then we have, you see some other drugs, analgesics, HIV drugs, and antipsychotics, among others. So when we get to chemotherapy and monitoring chemotherapeutic drug levels, we'll talk a little bit about the case for whether these drugs should be monitored or not. But for the most part, they're not routinely monitored. There's a couple exceptions. Methotrexate is a drug now that has been monitored for some time, and then busulfan is a drug in select centers where bone marrow transplantation is occurring. But outside of that, there really isn't a lot of therapeutic drug monitoring for chemotherapy. And so the way these drugs are managed is through traditional dose. They try to account for variability based on dosing to body surface area rather than in a typical milligram per kilogram approach. And so they will dose this based on a maximum tolerated dose that's been established. They will then measure the clinical response, as in monitoring the tumor, or look for adverse events, say hematologic toxicity or something else. And then they choose their next steps. Do they need to increase the dosage of the drug or the intensity of the exposure? Or do they just need to add another reagent or select a different chemotherapeutic agent? And then this process is repeated. And again, you'll recognize that as what we talked about just a few minutes ago, as the paradigm of titrate to clinical effect, and this follows it the same way. So the problem with this approach, or oncology drugs in general, is that it's a complex disease, and if you look at these comparative efficacy rates, you'll see some of the things we have here. I have oncology drugs outlined. You'll see some of even the basic drugs like analgesics, COX-2 inhibitors, where maybe it works for 4 out of every 5 people, and then you get to things like SSRI drugs for depression, and you're still only operating at a clip of about 2/3 of the people that respond to these drugs. And then you get to chemotherapeutics, and maybe 1 in 4 of the people respond to the drugs based on this survey. And really, why is that? Why do we have such a poor response rate? And I think that can be broken down here. So first, when you think about cancer, if we focus on that upper left-hand part of the slide, we think about cancer, it's really a heterogeneous disease. So just because you have pancreatic cancer, not all pancreatic cancers are the same. Same thing with all the lung cancers or the gastrointestinal cancers. Each of the cancers is a little bit different, and we know this because of the great emphasis on the molecular testing and genotyping of tumors to look for chemosensitivity. So there's a lot of difference between tumors that you may get between people, and then if you add that on top of it, this is the definition of the cancer is these out of control growth of cells, right? You get this alteration in your DNA, the cancer growth cycle becomes it's out of control growth cycle, and so these cancer cells are growing at a really rapid rate, and so you have this high rate of mutation as well. So the cancer that you get on day one, may not be the same cancer genetically 30 days later or 60 days later, and actually it may be a mix of different types of mutations in cancer cells, and some of those cells may be resistant, and so that makes it very difficult to treat, and that's something that therapeutic drug monitoring or pharmacokinetic guided dosing is not going to fix. The other thing we have to think about, if you look at the other upper hand right, is the nature of the drugs themselves. There are a wide variety of drugs that have a variety of pharmacokinetic factors. So they're absorbed at different rates. They are distributed. Some of them are hydrophilic, some of them are hydrophobic, some of them are metabolized very differently. And some of them are actually prodrugs where the metabolite is the chemotherapeutic agent. And so all of these things factor into that. And when we looked on our previous slide, that was really just lumping together all chemotherapeutic agents. And for some folks, maybe the response rate is significantly higher, and some folks it's a little bit lower, but there's a lot of variability. So you have the variability in the tumor, you couple with that with the variability in the drugs that are available, and then you have to think about the people themselves. There's a lot of variability in people. You think about variability in genotypes and phenotypes. So is somebody a fast metabolizer versus a slow metabolizer? Depending on the physician practice or the treatment paradigm, different people will be on different therapeutic regimens or co-administered drugs. Maybe some of the patients will be on antidepressants or anxiety medication. I'm certain for me that if I was diagnosed with cancer, I would have some anxiety, and so those drugs can implement. Some folks go to natural products or nutraceuticals to impact that, as we discussed earlier, and so you can have those drug-drug interactions. You can have the genetic variability between people, and then you have the non-genetic factors, right? Dietary factors. What's the regional diet for that person, and do any of those dietary factors play a role in the pharmacokinetics of the drug? What about obesity, morbidly obese patients? We look at pediatric patients versus geriatric patients, and they have very different, typically, organ functions and body water contents. And all of that variability in people contributes to this variability. So now you have this massive variability in the disease type or the tumor type. You have the massive variability in the drug type, and then you have, on top of that, the population variability. And with all that, it can be very complicated to treat the cancer, and leads to these low response rates. And so because of that, you know, the oncologists and the physicians that treat this cancer, they're looking for any tools that can perhaps assist them in doing a more effective management. So they're looking for any tools that may help them. Before we go too far, we also want to talk about how do you get to that maximum tolerated dose, because I think that's really important when you think about the ways that the cancer drugs are dosed, right? So they're given at this maximum tolerated dose, and you think about it in that it's in this modified 3x3 scheme. So you start with 3 patients here, and you give them the starting dose. And so this starting dose, and that's outlined in the study protocol, and they'll get this lower end of the dose, and no pharmacokinetic measurement, so no assessment typically of the blood concentration in terms of this consideration. So you have the 3 patients, you look at the starting dose, and then you look for grade 3 or grade 4 toxicity. Seeing no toxicity, then you do a dose escalation scheme. Well, now you give it to the next 3 patients, and this will continue until you get to the dose escalation level where you see 1 or more patients, so that's 1 out of 3 with a grade 3 or 4 toxicity. So let's say out of these 3 patients, 1 person had a dose-limiting toxicity, as outlined in the study plan. Well, at that point, we then repeat at the same dose level, okay? And if at that dose level, those 3 patients, 1 of those patients exhibits the dose-limiting toxicity, then you back down to the previous level. If at that previous level there is no dose-limiting toxicity, that becomes the recommended or maximum tolerated dose. But that is possible even if in that upper level only 2 out of the 6 patients demonstrated the dose-limiting toxicity. The other 4 may not have had that toxicity. And so it's possible at that point that the patients that didn't demonstrate the toxicity, they're not really getting the maximum tolerated dose. So in other words, maybe half to 2/3 of the patients aren't getting a true dose-limiting toxicity or maximum tolerated dose. In other words, they could still handle more exposure of the drugs. So the other thing we want to look at is this variability, because we talked about dosing to body surface area. And in the dosing to body surface area, the idea is that it really comes from a scale-up of animal studies into human studies. So the idea is that you'll have these the patients that you calculate the body surface area, and then you will dose to that body surface area, and that will account for the variability. But in this slide, I really like it. It's from a review in 2002. You'll see, like, for something like cyclophosphamide, this is the histogram is representing, if you look at the y-axis, it's the variability in clearance, which is a stand-in for variability, pharmacokinetic variability. And you'll see here that you have things ranging anywhere from 25% variability in clearance all the way up to 60 or even 70% variability. This is that 70% variability is irinotecan, meaning, so this is the SN38 metabolite. So irinotecan is a prodrug that's metabolized to SN38, which has the chemotherapeutic effect. But if you think about that, what that really means is that you're depending on the metabolism of the patient to generate the drug that is going to attack the tumor. And if there's variability, it's going to be more effective in some than others if there's variability in the metabolism. But the other thing I wanted to point to here is this line. This dashed line that you see, it's a little bit faint, but that's the variability across all these populations, or all these drugs in this study for body surface area. In other words, while the percent CV of the pharmacokinetics or clearance ranges anywhere from 25% to 70%, the body surface area is pretty constant at 15%. So if you're trying to normalize the body surface area, it's really not doing a good job of addressing all that variability. And so you can't just use dose and body surface area to normalize across your population. So we want to move into a couple of examples that are well documented in the literature. We'll start with, both of these agents are drugs that have been around for some time. The first one that we'll talk about is 5-fluorouracil. This drug is a pyrimidine analog that's used in many types of cancer. The mechanism of action is inhibition, irreversible, of the thymidylate synthase enzyme, and it's used in combination with other drugs as the basis for FOLFOX regimens or FOLFIRI regimens, among others. FOLFOX now, and there are multiple iterations of this. I think it's now up to 6, or I'm going to stop at 6, but there may be a 7 or 8 out there that I'm not aware of. But there are at least 6 FOLFOX regimens, where you're using leucovorin and fluorouracil and oxaliplatin in various combinations. And it is the 5-fluorouracil is metabolized by an enzyme, dihydropyrimidine dehydrogenase, or DPD, and that has significant inter-individual variability. So when you get, or if you get 5-fluorouracil as a patient, there is going to be some variability depending on the enzyme activity of the DPD. The half-life is approximately 10 to 20 minutes of this agent. So I want to point to some studies that have taken a look at pharmacokinetically guided dosing, and some of them are relatively old. This first study that I'll be pointing to is a study that was done almost 15 years ago by Fety and others. It was published in Clinical Cancer Research, and this is a multi-center randomized controlled trial looking at about 120 patients in head and neck cancer. The study design was such that patients were randomized to either standard dose regimen, meaning dose based on milligrams per body surface area, or a pharmacokinetically guided regimen. So in this study, the patients received cisplatin, followed by a bolus of 5-fluorouracil, and then a 96-hour continuous 5-fluorouracil infusion. So this is before the FOLFOX regimens, or this one at least didn't use FOLFOX. It focused on the 5-fluorouracil administration. And then they developed area under the curve targets, or drug exposure targets, based on the area under curve. It was the relationship of area under the curve for 0 to 48 hours, and then the area under the curve for 0 to 96 hours. So they did a pharmacokinetic assessment, and they established these targets. And so the results are pretty interesting. They look both at the efficacy and the toxicity. And if you'll look at this, the dark histogram box, or right here, is the standard dosing arm, or milligrams per kilogram. Milligrams per body surface area, and then the white box is for those that had pharmacokinetically guided adjustments. And what you'll see here is that in the first, back up two, if you'll see in the first one, they looked at the hematologic toxicity here, and that's looking at neutropenia or thrombocytopenia, and you'll see a statistically significant reduction in the patient group that received routine TDM relative to those that did not. Then if we move over to the middle, where we look at the mucositis toxicity, again, significantly different between the standard arm and the pharmacokinetically guided arm. Now, if you look at the digestive toxicity, which is the other grade 3/4 toxicity, in that case, what we're really looking at now, you'll see that in the TDM arm, it did have a slightly higher rate, but that really was not statistically significant in their analysis. So we would say that those are statistically equivalent and not different at all. So if we look at the response, or the efficacy, and in this case, what they're testing, and they're not testing for difference, they're testing for equivalence. So was there any difference in the efficacy of the drug? And they looked at patients that had a complete response, a partial response, and then the objective response, which is a combination of the complete and partial responses. And what's interesting to point out is that statistically, these regimens were equivalent in terms of efficacy. So by using pharmacokinetically guided therapy, there was a reduction in toxicity with no appreciable impact on the efficacy. In other words, they were able to effectively treat the patients while minimizing the toxicity. Now, if we move from head and neck cancer into colorectal cancer, there are a series of studies by this Gamelin group. I'll present only a handful of them today. But the first one we'll point to here is a 1998 study, which is a multi-center trial, not a randomized control trial, but where they were administering leucovorin followed by an 8-hour continuous infusion. The target range in this case was not an area under the curve, but once steady state is reached, they were looking for a blood concentration of between 2,000 and 3,000 micrograms per mil. Okay? And so, having defined their target range, they were able to take a look at the number of cycles necessary to reach the optimal therapeutic level. They were able to look at how the patients responded relative to the number of courses it took to reach the target level. And you'll see that the best responders were able to have their target level within 1 to 3 courses. Now, this is what's particularly interesting, I think, right here, which is based on the blood levels and the target they had of 2,000 to 3,000, they found that most people were not overdosed. Only about 10% of the patients really required lower doses of the drug, where almost 80% of the patients, or I guess a little over 80% of the patients, that required a higher dose of the drug. And another interesting finding is that the folks that responded well, their plasma levels increased. So while initially there may have been a necessary dosage increase to receive to achieve the therapeutic target, once that therapeutic target was achieved and the patients were responding to the cancer, then the dose had to be adjusted again to avoid toxicity. And they did find a correlation between acute toxicity and levels greater than 3,000 that was highly significant. So again, they found that many patients were underdosed, and they were able to avoid toxicity by keeping the patients under that target of 3,000 micrograms per mil. Jumping forward a significant amount from that previous 1998 study to a 2000 2008 study by the same group. This is a study done in the journal of published in the Journal of Clinical Oncology, and this was a randomized controlled trial incorporating pharmacokinetically guided therapy as well as the standard dosing regimen again, and this was with the FOLFOX regimen, I believe. But what's interesting here is you'll look at arm A being the arm A is the standard dosing, and arm B is the pharmacokinetically guided dosing. And what you'll see is that you'll see patients did better or had an improved clinical outcome in the pharmacokinetically guided arm of the study relative to the non-guided arm of the study. In some other work that may have been published later, but the slide that I have here is from from an abstract that was submitted at ASCO. You'll see that this was another phase 2 study using FOLFOX, where there were almost 120 patients with metastatic colorectal cancer, and then about 40 patients that had that were given in the body surface area group. So about a 3-to-1 ratio of patients that were getting pharmacokinetically guided therapy relative to standard dosing. But what was interesting is the findings. So when you look at the toxicity of the group, arm A being the standard dose and arm B being the PK guided dose, you'll find that you see significant reductions in diarrhea, mucositis, and but not hematologic toxicity. So where you saw a reduction in the diarrhea and mucositis, but no reduction in the hematologic toxicity. So there was some reduction in the toxicities. Now if we look at the response, you'll see the positive, well, let's look at the arm instead, arm A, the standard dosing. You'll see that the positive response was about 46% and the non-responders 54%. So about a 50-50 mix of responders and non-responders. And then if you look at the PK-guided arm, you'll see a 70% positive response rate relative to a 30% non-response rate. So based on this data, what you're looking at is you see a reduction in toxicity and in addition to an improvement in response rate. And then we have the survival data, which shows in progression-free survival of 10 months for standard dosing relative to 16 months in PK-guided dosing. Or if we look at the median, and this is median progression-free survival and median overall survival, in these groups you saw a median of 22 months for standard dosing versus 28 months. So again, this is data that implies that the pharmacokinetic guided dosing does give some benefits to patients. Another study I just want to touch on, this is again from an ASCO symposium. This is out of the Wenstrup group from 2010. And this was looking at plasma samples from patients receiving FOLFOX6 over 44 to 48 hours for adjuvant and metastatic treatment of colorectal cancer. And they were looking at an immunoassay called ONDOS that was measuring 5-fluorouracil. The thing that I want to point out from this study is really the dose narrowing. So we've shown that if you're able to establish this target therapeutic interval, you'll see that during the first cycle of treatment, where the blue box is the therapeutic target, there's really almost no one in the therapeutic target, and you see this extremely wide spread of values all over the area under the curve. Contrast that with the fourth cycle as you pull the data and using this pharmacokinetic data to be able to modify the dose, and you'll see by the fourth cycle many more patients are within or in the fringes of the therapeutic target. And this may be highlighted a little bit better if we show the table so you can see the numeric data, where you'll see in sample 1 or in the first cycle, you'll see our target of 20 to 24 for AUC, and you'll see that only 2% of patients are in that narrow box, and then another 50% of patients are in the fringe area of this. So if you compare that with sample 4, where you've gone from 3% to almost 40% of patients in that narrow therapeutic target, and then you have an additional almost 50% in the fringe for a total of 50, 47, 80, almost 85%, a little over 85%. So you have much higher in this therapeutic target window, and I think that is evidence that using this pharmacokinetically guided data, you can, and if you're willing to jump in and make the dose adjustments, that you can certainly drive toward a therapeutic target interval. The last study I wanted to show on 5-fluorouracil is a pharmacoeconomic study. So this is looking at cost effectiveness of pharmacokinetics. And so this is somebody doing modeling based on the data, some of the data that I already showed and some other studies that were out there where they're looking at body surface area guided relative to pharmacokinetically guided FOLFOX regimens in metastatic colorectal cancer. And this is really just an empiric representation of the model. So they're looking at the administration of these regimens and then what second line treatment is needed once the disease progresses, and then ultimately looking at death as the endpoint as they calculate the quality adjusted life years. And what they found was that as they compared these groups, they took into account all the different types of adverse events and the progression-free survival and overall survival. And what they found here is an incremental difference of, or an increase for PK-guided FOLFOX therapy of about a little over 1/2, 0.573 quality adjusted life years, with an incremental cost of $13,000. When they get to the incremental cost of effectiveness rate, that's where they were seeing about per quality adjusted life year, they were really seeing about $23,000, maybe a little less than that, where it does cost more to administer the PK-guided FOLFOX therapy, especially if patients are living longer. That means they're going to have additional cycles of therapy amended. If you remember back to the data we showed previously, many of those patients that are having pharmacokinetically guided therapy require dosage increases, which are going to cost more in terms of the first-line chemotherapy. But you do see a reduction in second-line chemotherapy because it's a slower to progression. And then the last analysis they did was looked at this relative to a cost-effectiveness acceptability curve, and finding that the 22,000 is very close to the midpoint of this cost-effectiveness acceptability curve. And so they found that depending on what the willingness to pay is, certainly this gets if the willingness to pay is at $40,000, then it's certainly possible that an incremental increase of $22,000 to $23,000 certainly fits within that, and people are likely to adopt that type of thing. Okay. We'll shift gears a little bit and move from the solid tumors and 5-fluorouracil into imatinib. So imatinib, there's additional interest that's being generated in other tyrosine kinase inhibitors, but we'll focus on imatinib, which is a TKI that's used in treatment of CML or gastrointestinal stromal tumors. For CML, the drug targets the BCR-ABL tyrosine kinase, and in GIST it targets the c-KIT. It's primarily metabolized by CYP3A4 and 5, which means there's a high degree of pharmacokinetic variability between individuals, and the half-life is significantly longer, so it can be given as once daily dosing and can be given as outpatient chemotherapy in some cases. And anytime you're giving somebody a pill to take home, now you're starting to bring into the equation this issue of compliance. Are people really taking their medication the way that they're supposed to? So when we're assessing the CML response to therapy, because the response to imatinib in CML the response to imatinib in CML is followed through looking at transcript levels of BCR-ABL, and it's expressed as a log reduction from a standardized value. And there are 3 different levels we'll talk about, which would be a 2-log reduction would be called a complete cytogenetic response. A 3-log reduction in transcripts is the major molecular response, which is 3-log reduction. And if the transcripts become undetectable, that would be categorized as a complete molecular response. The major objective of the therapy is the 2-log reduction in transcript, because that's associated with prolonged survival. And we can demonstrate that in this. You'll see it's a little bit different of a figure. This is from a JCO paper in 2012. But you'll see the blue line is the if the 3 months transcript ratio is less than or equal to 0.61%, you can see the incidence of a complete molecular response. Whereas if you don't get to that transcript ratio, 3 months transcript ratio of 0.61% or less, your chance of getting to complete molecular response is much lower. And what that data really emphasizes is it's important not just to get to the lower transcript ratio, but to do so quickly. And if you want to do it quickly, that means you have to make sure that you're at an effective dose of the chemotherapy once the leukemia is discovered, and you want to get there quickly. And make sure that people are adherent. This slide is a little bit busy, but I wanted to put together this information and show a couple things. We'll start actually in the upper right-hand corner of the slide. And in this slide, what it's demonstrating is the distribution of the concentration of imatinib based on different dosages. So the different colors correspond to different dosages ranging from less than 300 milligrams to more than 400 milligrams. And it's important to point out at this stage that in this case, it's not really dosing to body surface area. The drug is being dosed at a flat rate. So it's being given at a standard dose of 400 or 300 or 600 milligrams. But when you look at the different dosing, you can see that only about half of the patients are at a concentration, a steady state trough concentration of 1,000 nanograms per mil or less. So the question is, why is that important? Well, if you look at this study, this is from a review from the Takahashi paper listed here. You'll see that they've looked at a bunch of different studies, and in each case they're looking at the imatinib trough concentration. You'll see concentrations here of 900, 1,000, just shy of 1,000, 999, just a little over 1,000. And in each of these cases, with the exception of these two studies by Forrest and Widmer, all the other ones show a correlation of the trough concentration with response, whether that's complete cytogenetic response or major molecular response. And if you look at this figure in the bottom right-hand corner, you'll see that, and looking at the distribution here, you'll see that in this grouping of patients where they measure the trough concentration, in the grouping of patients that have a trough concentration greater than 1,002 nanograms per mil, almost 75% of them achieved major molecular response, whereas the patients with less than 1,002 nanograms per milliliter had a major molecular response in just under 60% of the cases. So all of these imply, again, that having a trough concentration of imatinib greater than 1,000 nanograms per mil is an important predictor of treatment success, perhaps more important than the dose that you actually take. We want to look a little bit at adherence, which is going to be related to the blood concentration, right? Because if you're not taking the drug, it's not going to get into your bloodstream. This was an interesting study from 2010 where they measured patient adherence by a couple of different ways. The first way was pill counting, and that's something that's been around for a long time. The other way to monitor this is something called MEMS. It's a medication event monitoring system, and it's a really interesting device that has a radio frequency tag in the top of the cap. And what it does is it records every time you open the bottle. So you could open the bottle one time, pour out 30 pills, put the top back on, and take it back. They'll count your pills, and it will look like after a month you've taken all the pills, but the physician will be able to know that, well, you didn't open that bottle 30 times, so you're clearly not taking it once a day, therefore you're non-compliant or not adherent. And so in this study, the investigators told the patients about pill counting, but they didn't tell them about the MEMS cap. And so they were able to have an objective measure of whether the patients were actually adherent to the regimen or not, and the degree to which they were adherent. Were they 90% adherent, 75% adherent, 50% adherent? And then they were looking at the response to the medication by measuring the BCR-enabled transcripts. And then they did some other measures as well in terms of looking at genetic mutations. Now here's what's interesting. If we look at the top category here of adherence, the blue line is adherence of greater than 90%. The yellow line is an adherence of less than 90%. And so if you look in panel number 1, you'll see that there's a significantly higher chance of major molecular response if you're 90% adherence versus, and remember that's a 3 log reduction, versus those that were less than 90% adherent. And remember, that's a combination of anybody who's 88% adherent or 2% adherent. So that's a large amount to lump into one thing. If we go to the middle, which is a 4 log reduction, so we have the 3 log reduction, which is major molecular response. We have a 4 log reduction, which is the the next step down. And then we see in the bottom line, which is if you're less than 90% adherent, you have almost no chance of complete response. One other thing to note from this study is looking at the concentration, right? The imatinib plasma level. So even though it wasn't an endpoint of the study in terms of informing the decisions, these patients did have blood drawn and they measured the trough concentrations. And if you look at the major molecular response and the plasma level, what do you see? Those that had a plasma level of less than 1 microgram per mil, which is 1,000 nanograms per mil, had a response of 60%, whereas those with greater than 1 had a response of had 83%. If we go to the complete molecular response, you'll see those with a plasma level of less than 1,000 was 23%, whereas those that had a plasma level of greater than 1,000 nanograms per mil or 1 microgram per mil had a response of a complete molecular response of 44%. So clearly there's something associated with this trough concentration that seems to be a reasonable cutoff. So if we shift gears from leukemia and go into the gastrointestinal stromal tumors, this was an interesting study that was done in 2009 looking at patients randomly assigned to receive imatinib 400 milligrams versus 600 milligrams daily. And then in a subset of these patients, they looked, in about 70 of them, they looked at PK data, they looked at the plasma levels, and they looked at the relationship between exposure and clinical outcome. But they did it in a way where they didn't do it in a continuous way. They grouped the patients into quartiles, and then they looked at the response rate plus stable disease, they looked at time to progression, and then they also did some analysis looking at the KIT genotyping versus favorable mutations versus unfavorable mutations. So this is a really interesting slide from the paper, I think, which demonstrates, so that the patients getting 400 milligram doses are in the yellow, and the 600 milligram doses are the blue labels. And you'll look at each of the quartiles, you'll see that there are some from each dose, right? Even in quartile 1, the lowest concentration, you still see some that are getting the highest dose, right? And in the quartile 4, you see some that are getting the lower dose. And this clearly demonstrates that there's a lot of pharmacokinetic variability associated with this drug, whether that's due to adherence, whether that's due to pharmacokinetic variability between the individuals. There's still a lot of that variability there. The other thing that is really interesting to note, if I can draw this line here, you'll see at that cutoff of the quartile, that's right around the 1,000. It's a little bit higher, but the dividing line from quartile 1 from the rest of the group is right around 1,000 or a little bit higher, and that's going to be significant when you look at the data analysis. So let's look at our quartile 1 versus quartile 3 and 4. So if we look at line 1 of this table, So the gray up here, this is looking at all patients, so it's not separating out any mutations. And what you'll find is that when you're looking at the overall response, you'll find a response rate of about 67% in quartile 1, whereas quartiles 2, 3, and 4, in quartiles 2 and 3, you have the middle 50%, you have an 81% response rate, and you have an 84% response rate in the highest quartile. All right. Now, if we look at those with exon 11 mutations, which makes them more sensitive to the imatinib therapy, you'll see that in the lowest quartile, we have a response rate of about, that number's small, but it looks like right around 67%. And now if you look in the highest quartiles, you'll see in quartiles 2, 3, and 4, we have 100% rate when you consider all the outcomes, the partial response, stable disease, and complete response. Now if we look at the exon 9 mutations, which we could consider more resistant to the treatment, you'll see the quartile 1 is a 67% response rate when you consider stable disease plus complete and partial response. Quartile 2 and 3 has a similar response rate to quartile 1, but in the highest quartile, you see 100% response rate with an N of 1. So I'm not willing to draw any conclusions to say if you have the exon 9 mutation in KIT that you're going to do better if you have the highest imatinib concentrations, but it does maybe beg the question as to whether that should be investigated or not. But clearly, again, coming back to that quartile 1 and the poorer response rates, again, that sort of points to this trough concentration of 1,000 nanograms per mil as being a potential therapeutic target that we should pay attention to. And here, if we look at, again, the progression-free survival relative to time since start of treatment, and you'll see the quartiles 2, 3, and 4 seem to be pretty well similar, but the quartile 1 patients definitely do worse. And those would be the patients with trough levels less than 1 nanogram per mil. So we'll move to this last set of studies that I'll talk about today, which is there is first a population pharmacokinetic study done in 2014, so earlier this year, or it was published earlier this year. And this was just taking a group of patients that were getting a standard dose of 400 milligrams of imatinib, and then looking at the trough concentrations, and then looking at clinical events relative to those trough concentrations. And the thing I'd point out in this is just a plot of the distribution, and you'll see again that there are many, many patients at this dose of 400 nanograms per mil, 400 milligrams that have a trough concentration of less than 1,000 nanograms per mil. The median would actually be right around, which is the dark line here, is at about 800 nanograms per mil. And so you can see this plot here. If we shift it a little bit, now this is doing on the population basis with the variability, you'll follow the dashed lines, and it's clear that there is a response in these investigators' study where you see an increase in probability of improved outcome, which is cytogenetic response, the molecular response. So the probability of those types of responses increases with increased trough concentration of imatinib. And then you'll see that there is an increase. This lowest one is the increase in adverse events, probability of adverse events. And that probability does also increase with dose, although it would appear that it increases at a lower rate than does either probability of major molecular response or complete cytogenetic response. So especially if you're looking at this, increasing the plasma concentration or the trough concentration of imatinib significantly increases your chance of a major molecular response, while much less increasing your chance of adverse events based on this plot. And so based on those findings, the same group, and this is a paper that is just recently electronically available. It's EPUB ahead of print. I have the reference here at the bottom of the slide. And this is where they went to do a randomized control trial to build on that pharmacokinetic work. So based on this work, they determined with a small number of patients, only 56, but they randomized to what they would call the rescue TDM group. So this is a group that got standard treatment, but if the patients they were still getting the blood concentrations measured, and if the patients were doing poorly, they had the ability to go back in and access that the blood concentration data and make dosage adjustments based on that. And then they had the other half of the patients that were allocated to a routine TDM, which means that during this they would get the Cmin or the trough concentration result along with a dosage recommendation. And so the dosage recommendations were not strictly a strict pharmacokinetic guidance. What they were would be they separated the patients into bins. So if you were close to the therapeutic target, you might increase the dose by 25%. If you were further below, you would increase the dose by 50%. And if you were, in the lowest tier, they might suggest that you increase that you would double the dose of imatinib that the patient would receive. And so, but they in each case, whether it's rescue TDM or routine TDM, they would give the physicians not only the result, but a dosage recommendation. And in evaluating the data, what they found was not a lot of value. Right? If you look at just the routine TDM versus the rescue TDM, you don't see any significant differences. It doesn't seem to demonstrate the value, which puzzled the investigators, and they went in to do a little additional digging. And what they found was that in many cases, even though they gave dosage recommendations, those dosage recommendations were not followed. So if you go into the routine TDM, which is the figure on the right-hand side, you'll find that when they look at the subgroup analysis, you're getting the solid black line up here. These are patients who followed the protocol. And then in the dashed line down here, these were patients who did get the TDM results, but the physicians, for whatever reason, did not make the dosage adjustment as recommended by the protocol, or maybe they made a dosage adjustment, but just not the full amount. But in either case, if you look at, and this is a very small number of patients, so again, it's hard to make a definitive statistical conclusion from this, but what you'll see again is it suggests that if the patients or the physicians followed the protocol according to the blood level monitoring of the drug, those patients fared better than those who did not follow the protocol. So based on this data, is there a rational way to use this data? What's the best way to approach this? Because you have to have some guidance. And how do you use this relative to a lot of the data that's out there in terms of genotyping? Because that, in terms of companion diagnostics, that's where a lot of the emphasis is today. And I don't think that it's competing priorities. I think really that this is an area where there could be a lot of complementary value by using both genetic testing and pharmacokinetic assessment. So this is a really nice figure that I wish I had done, but this guy, Judson, in Clinical Cancer Research published this a couple years ago, and I think it's fabulous. So he it starts with diagnosis of advanced GIST, and this can be based on molecular testing or tumor marker testing or clinical evaluation, but once you determine that the patient has the disease, then you go in to make an assessment of whether or not they have a favorable genotype. In this case, we're looking at the KIT genotype. So as we mentioned, if you look at the unfavorable genotype, if you have the most resistant genotype, the exon 9 molecular test, we're not going to mess with the pharmacokinetic testing. We're going to go to the absolute maximum dose, which is 800 milligrams daily. Now, if you have an unfavorable genotype, but it's wild type or resistant genotype, and you have to go in a different direction, then perhaps they would go with a different tyrosine kinase inhibitor. So again, it doesn't help you with the dose. It tells you select a different therapy. Now, if you diagnose somebody with the tumor and they find the mutation analysis that shows a favorable genotype, then it suggests, well, let's start with imatinib. And here's where the complementary part takes place. Now you know that the tumor should be sensitive to the drug, so now let's make sure that the appropriate exposure is taking place. By doing that, we do that with blood level monitoring, and we do a response assessment. So we have the therapeutic drug monitoring, and we have the response assessment 3 months or sooner, and then we repeat the PK study down the line. So this would be a continuous cycle. Now, if we have the blood level data, we have the response assessment. If we're seeing a poor response or progression, then perhaps, and we have a low trough level, meaning minimal or not sufficient exposure to the imatinib, then you can increase the dose. If, on the other hand, you have a poor response, but your blood level is within the target range, then perhaps it's time to change to a new agent such as sunitinib. If you have a good response, and an adequate blood level, then you continue. If you have a good response but you have a low trough level, you still have the opportunity to increase that imatinib and perhaps get to a complete cytogenetic response a little bit more rapidly. And then you would continue to cycle this until you achieve the CMR or stable disease. And as long as they're on the imatinib, you would continue the PK study to make sure that things haven't changed. And that change can mean addition of an additional drug or nutraceutical that will change the metabolism. It could just be somebody who thinks they're feeling good and would stop taking the drug. Regardless of the reason, you'll want to make sure that if this is a disease the patient is going to live with for an extended period of time, you want to make sure that they're taking the medicine the way that they're supposed to. And so this fits into a bigger idea, which is, I don't think it just fits for imatinib or for 5-fluorouracil. There's a way that we can use these tools available to us to take a comprehensive approach to precision medicine or precision chemotherapeutics. So the genetic testing is vital in finding chemosensitivity, characterizing the tumor, and trying to pick the exact right drug. And then we want to either using biomarkers of response or drug levels, and either one or both, we find a way to measure the ongoing response for the non-genetic factors and make sure that we're optimizing that therapy. And if we need to make modifications to either the dose or change the drug, we can do that faster by using these tools and not waiting just for assessment of imaging or looking for hematologic or other types of toxicities. We can really make these assessments earlier, which allow us to modify the dosage earlier if needed. And with that, I'm happy to take any questions with my time left. So I do have some questions that I pulled up here. This is the first question, it looks like, from Barbara Stout, which says, what's a typical toxic effect that is looked for during the determination of maximum tolerated dose? And I would say that typically it really is dependent a little bit on on what the drug is and what its clinical effects are. But we demonstrated some of these here, which typically, we're following these patients looking for hematologic toxicities or GI toxicities, and then there may be some other toxicities that go along with it. But definitely hematologic and GI toxicity are two of the big ones. This looks like it's a question from Maggie Aros. It says, what are the factors that are assessed in the PK arm of those studies? So in the PK arm of the studies, they're assessing, and again, this depends on the type of tumor and the type of drug. So when they're assessing they're looking at the drug exposure. So in many cases, it's not a single time point, but they're assessing the pharmacokinetic exposure by the area under the curve. And then in many cases in these PK studies, they are looking at confounding factors such as potential drug-drug interactions or genotypes. Once they've assessed that pharmacokinetic exposure, then again, they're looking at toxicities, which is a little bit relative to the question that I just answered for Barbara, and they're looking at these toxicities, but then they're also looking at the drug efficacy, which in this case would be, in the case of chemotherapy, would be that BCR-ABL transcripts. In some cases, it may be looking at tumor size or additional biopsies and things like that. So I think it depends on the type of tumor, but you're looking at whatever it is in that particular disease relative to that particular drug and its associated toxicities. You're looking at both biomarkers or clinical assessment of toxicity as well as efficacy of the drug, and then looking at that exposure and what may impact that pharmacokinetic exposure. Let's see. This is another question from Barbara Stout, which asks, with the MEMS case, how do they account for the frequent use of weekly and monthly pill box that many folks use? So in this case, I think that they get, I have not been involved, up front, I haven't been involved in any of these MEMS studies directly. So my understanding is that, if I'm understanding your question correctly, that they would have a special container, so they wouldn't be able to use the same pill boxes that they use that would contain their other medications. So for the imatinib, they would have a container that only has imatinib and wouldn't be impacted by any statins or antidepressants, anti-anxiety drugs, or vitamins or anything else that they take. So they would have a separate pill box dedicated only for that. And I've seen them do that with imatinib, and then this is also frequently used for adherence studies in psychoactive drugs as well. So that's how they would separate that out from all the other pills that the patients are taking. This question is from, I apologize if I don't get your first name correctly. It's Emer Sheridan from the University of Huddersfield. And the question they ask is, don't you think this is exactly what pharmacists should be doing? And I would say definitely pharmacists should be involved. I think that what we're working toward within our institution is the ability to work with pharmacists. So we think that the lab and pharmacists should be working together to give this consultative and supportive surface to the oncologist treating the patient. So really, I don't think pharmacists should be doing it on their own, although I will say pharmacists in our institution are doing this with some of the antifungal drug monitoring, aminoglycoside monitoring, and other drugs, and we support them in that by helping them understand the limitations of the testing, the analytic variability versus the biologic variability. But I really think it's not just pharmacists or just lab or just oncologists. I think for this to be successful, it's really it takes a confluence of people where you have the oncologist working with the molecular pathologist, working with the pharmacist, working with the laboratory, and taking this multidisciplinary approach. And if that's done in a truly flat way, I think that you can utilize these tools to affect better outcomes. But it has to happen like that, and we have to have the tools to be able to support it. Right now, many of the healthcare information systems are so siloed and not integrated with these different pieces of information, it's difficult to pull everything together. So I think that can be problematic. But yes, pharmacists should absolutely be involved in this process. This is a question from Ryan Matsuda at the University of Nebraska-Lincoln. I went to the University of Nebraska-Lincoln, so I'm glad you're on the call here. So it says, how about the formulation type in improving patient compliance and adherence? And that's absolutely, certainly a factor, but that becomes more of a variability issue. I'm sorry, a behavioral issue. I don't know why I said variability. That becomes a behavioral issue because now you're talking about, some people prefer to take pills, some people absolutely don't want to take pills. And so the formulation type, I'm sure, plays a role in that. If they can get to where you could get imatinib by a patch that you would put on once a day or week, like they can do with ADH medications or pain medications. But there's a lot of work that would need to be done in that, and I'm not aware that work, at least nothing that I've seen published on this, but that doesn't mean it's not underway. But certainly, formulation could be a consideration. But then you also have to take that into account in terms of the drug exposure. So the pharmacokinetics will vary relative to the formulation, and that's important to consider too. This is a second question from Emir Sheridan. This is a question about point-of-care testing. I'm going to encourage you, if you would, take down my email address. And this is probably a question that would take a lot longer to answer than over a video camera. But I'd be happy to correspond with you via email or by telephone to discuss this point-of-care testing. So happy to engage in that topic. But just send me an email and we'll coordinate an offline conversation about that. And say hello to Dave and everyone else back at University of Nebraska, to Ryan. So I think that's all the questions we have. We're out of the questions, and it looks like my time is over. So I appreciate your attention for the webinar. Thank you.